Now, remember that one of the points I've already made is that lupus patients don't die of active lupus. The major cause of death in the Western world is cardiovascular events. And of course, there's also, unfortunately, deaths still from infection. In rheumatoid arthritis, there's already a handle on how to use cardiovascular risk formulas. And they have a very simple method of just multiplying the existing risk formula and using that to tell the patient what is your risk of cardiovascular events. Lupus is so heterogeneous, I don't think we can have a simple multiplication factor. I think if we're going to do better at identifying and treating patients at greatest risk, we're going to have to individualize it with all the different risk factors. So nothing as simple as let's multiply Framingham by 1.5. So how bad is the risk? We believe, at least in Baltimore, that our lupus patients have a 2.66-fold increased risk of cardiovascular events over the general female population. And this is often forgotten, that lupus should be right up there with diabetes in terms of understanding the risk of cardiovascular disease. Now, even if we look very early, so if we do a cardiac CT to measure a coronary calcium score, lupus patients have a twofold increase in these non-invasive measures of very early preclinical atherosclerosis. And you'll remember I've already shown you this slide that it's not just lupus. It's not just traditional cardiovascular risk factors that are causing this problem. Prednisone is right in there as well. So you can see how multifactorial it is and how difficult it's going to be for us to improve this, or hopefully someday completely eradicate this accelerated atherosclerosis risk. When we did a study of statins, we did look to see what are the risk factors for progression of atherosclerosis that's already there. And it turned out that there were a lot of risks that we see in the general population as well. And depending on what vessel we looked at, the risks were slightly different. So for coronary artery calcium, age, smoking, and of all things, a low high sensitivity CRP, not a high. For the carotid intima media thickness, it was age and hypertension, and for carotid plaque, it was age and hypertension. So you get an idea here. We can't escape being general internists when we're treating our lupus patients. We have to treat these traditional cardiovascular risk factors to target. Now, the HSCRP story in lupus is very interesting. Remember that in the general population in women, HSCRP may be just as important as LDL cholesterol as a risk factor. Turns out it doesn't work well in lupus patients, where the HSCRP is affected by a lot of things, including weight. It's not just a cardiovascular risk factor. And when we studied it, it doesn't predict which lupus patient is going to have a myocardial infarction or angina. I want to show you what we did find. We looked at 100 cardiovascular events in my lupus cohort and asked what were the predictors. So in other words, let's start from scratch and build a lupus Framingham risk formula for cardiovascular events in lupus patients. And these were our model results. Now, the things that we can never change, of course, are patient age and patient gender. And then you see that there are a lot of the traditional cardiovascular risk factors like hypertension, cholesterol, smoking, diabetes. I want to draw your attention to the last three on the list. Here we see some lupus-specific risk factors for cardiovascular events. Overall disease activity, that's that SLE disease activity index. The lupus anticoagulant, so the most important antiphospholipid antibody, and then a low C3, so a serology. So already you see the complexity of this risk formula. It's going to include traditional cardiovascular risk factors, but it's also going to include lupus-specific factors.